Okay, it's Ros Murray here. I wanted to just mention Takotsubo cardiomyopathy, an acute neurological disease, just having come across it recently. My memory of this condition from years ago in medical school was that it was very benign, very, very rare, and essentially nothing to be concerned about, very transient. And that's no longer really thought to be the case. So, also known as broken heart syndrome, apical ballooning syndrome, and stress cardiomyopathy, Takotsubo cardiomyopathy probably makes up around 2% of cases of acute coronary syndrome, so it's not that rare. First described in a case report from the 1990s of an episode of multivessel spasm causing heart failure that made the left ventricle look like this Takotsubo, this octopus catching pot used in Japan. And this is the standard form of the myopathy and how the left ventricle looks. So in the mid-2000s, the Mayo Clinic produced diagnostic criteria. It's transient regional wall motion abnormalities, not in a single coronary artery distribution, with no evidence of an obstructive coronary thrombosis, but is associated with, for example, 50% vessel disease rather than acute thrombosis. You get new symptoms with new ECG abnormalities that look like an MI, such as the ECG shown there with ST elevation, and the ECG evolves similar to an MI with T-wave inversion over days. And no evidence of pheochromocytoma or myocarditis, because pheochromocytoma produces high levels of catecholamines, which are thought to be the main way that this condition causes the cardiomyopathy. So as you can see there in the graphs below, there are higher levels of circulating catecholamines in patients with this sort of cardiomyopathy compared with normal MI. The symptoms most have chest pain, breathlessness, evidence of heart failure, but some present with syncope, cardiac arrest, or stroke, in fact, from thrombosis in the left ventricle. A vast majority will have a raised troponin, but the level of the troponin doesn't necessarily relate to the severity of the hypokinesis of the left ventricle, and brain natriuretic peptide levels, a marker of heart failure, tend to be raised. The pathophysiology is still being worked out, but supraphysiological sympathetic activity, probably originating in the brain, causes microvascular dysfunction of the coronary vessels, and depending on the density of the beta receptors of the sympathetic system within the myocardium, different shapes of the left ventricle and degrees of heart failure. There's thought to be direct myocyte toxicity as well. There is a Takotsubo registry, which is international, and there's now about 2,000 cases. And the information from that is that this is a condition of postmenopausal women. So it tends to be females in their 60s, although there's some evidence that some of the neurological cases, in particular linked with epilepsy, may be younger, particularly in the men, and less likely to present with chest pain. But usually there is 44% ST elevation, a minor proportion ST depression, and close to 50% QT prolongation. 50% of these patients have had a preceding psychiatric or neurological episode. The triggers, 36% physical, such as an illness, a stroke, a fracture, or surgery, sometimes even post-ECT. 27% an emotional trigger, such as the typical thing was a bereavement with broken heart syndrome, profound emotional disturbance. And I think of it as the most obvious functional condition, whereby it's obvious that your emotions affect your physical health. Around a quarter, though, will have no obvious trigger. Mortality is 4% at 30 days, so it's not benign. Recurrence rates 10 to 15%. And particularly with epileptic seizures, actually, that was the case with this patient recently. It had 3 admissions with Takotsubo type ECG changes, and there seems to be a lower risk of recurrence if the patient's put on an ACE inhibitor or an ARB. So in acute neurology, look for it. Subarachnoid hemorrhage seems particularly associated. Status epilepticus also, particularly generalised seizures, but other conditions as well, and there's a higher chance of it if you suffer migraine. It does tend to be more female admissions, and a recent review said that this affects around 1 in 1,000 epilepsy admissions and questions the role in SUDEP. So I think it's just something that we should be aware of.